Welcome back, and thank you for staying with us. We now cross gears into the health segment this Wednesday. We appreciate your time and company. And like I told you when we were starting this program this morning, we are going to be looking into cancer treatment and care. And I'm hosting this morning Dr. Bridget Nyabuto. She's an oncologist. She's joining me virtually just to discuss the state of cancer in the country, cancer treatment and care, and also tell us the special focus of radiotherapy as an area that is very pivotal in treating cancer in our country. Thank you so much, Daktari, for joining us for this very special conversation. Maybe to begin, by you getting your perspective on the state of cancer in our country this particular morning. Have we made progress, and what will be your key concerns with regards to even the status of the treatment options that we have within our borders?
Good morning.
Good morning, Dr.
Thank you for having me.
Yeah.
I hope your day is as beautiful as mine wherever I am. Yes, cancer, the one monster everybody fears, the one thing that for most people kind of spells a death sentence. Yes, we've made strides as a country, very, very, very great strides. In terms of radiotherapy, currently there are more machines in the country. And secondly, also CyberKnife, the one thing that used to make it necessary for patients to get to India is actually well within the country. That's at KU Hospital. So yes, we've made progress. However, still, the facilities available are inadequate, number one. And still, patients are not getting the easily accessible, the easily affordable and quality healthcare they deserve. And the worst of all, some of them have been waiting on that list for a tad too long. So yes, strides have been made on the positive, but there is more that can be done.
So the cancer is no longer a death sentence. That's what you're saying in the context of the progress that we have made, in terms of addressing cancer in our country. I'd like you to also tell us a bit about, today it's all about cancer treatment and care, Daktari. Take us into the world of the options that are currently there for cancer patients. What is it that we have, and what factors are considered in choosing one type of treatment vis-a-vis the other?
Oh, that's a rabbit hole, but let's see if we can delve at surface level. So the treatment of cancer, number one, you have to identify the type of cancer it is. So there are hematological tumors, and also there are solid organ tumors. Apart from that, you go by the region involved. Okay, and then next, you look at what we call staging. This is assessing the extent to which the disease has spread. Yeah, apart from that, there are other factors that are considered, something called immunohistochemistry. This is what those diseased cells look like on a microscopic level. You study the channels they use to sustain themselves, that's their food, and any other biochemical reactions, and you see at what point you can break that. Yeah, makes sense? Like how you can manipulate those channels to sneak in substances that will kill these cells. So something we call immunohistochemistry. Mm-hmm. Now, depending on the stage, let's pick, for example, a very early breast cancer. You can begin by surgery, that's radical surgery, and then followed by chemotherapy. That's the one where we put the chemicals into you, either orally, there's oral chemo, by the way, in some options, and then there's also chemo through the line or intravenous. Yeah, so there's surgery if the tumor is amenable to surgery and you're coming out with clean margins. Then there's chemotherapy, then there's radiotherapy for some tumors, and then there's what we call immunotherapy, and for breast, there's hormonal therapy, breast, and then there's also androgen suppression, that is hormone suppression for prostate cancer in men. So the options are quite broad. It really diagnosis and to staging. And above all, also our goals of therapy.
All right. Take us into the area that you specialize in, the radiotherapy. What sort of cancer treatment is it, and what does it entail, Daktari?
Okay, so let me put it, how do I begin?
In a simple,
yes,
trying to find a simpler way of explaining it.
In training, so we basically use radiotherapy to target the tumors, yeah? We use radiation therapy to kill the cancer cell, the bad cells. Let's see, how do I put it? Yeah, we take these rays generated from machines, okay, that are cytotoxic, that is harmful to the bad cells. And then in a carefully calculated and mapped out manner, like this is a game of precision, we now target the involved areas. We've actually progressed, there's even precision, we can literally perform surgery on your brain, assuming it's one target lesion, for example. There's a way we radiate around it, yeah? Very precise, very targeted, yeah, called CyberKnife. So it's a whole new interesting world. It's a whole different ballgame, but it does work. Mm-hmm. It does work. Mm-hmm. And patients have to give their testimonies. Yeah.
All right. You'll share with us a bit about the success rates and the success stories that you have interacted with. But before we get there, Daktari, I'd like to hear probably for a patient who has come in for treatment. Before you decide to go the radiotherapy direction, do you decide what stage of cancer is it, or is it a treatment that is just administered as an option for any stage of cancer?
Oh, very good one. We first of all, as we discussed earlier, before you begin crafting or fashioning a treatment plan for a patient, knowing where they are, their staging is very essential, mm-hmm. which again also advises you on number one, your goals of therapy, because now there are some patients you aim at a cure, yeah, mm-hmm. especially in early stages, and then there are some your main goal becomes making life easier, making life better, aka palliating. Okay. Yeah, so for radiotherapy, we mostly target the early stage tumors, and depends again on if the tumor in question is radiosensitive, because there's no point you run radiating something that will not respond to the radiotherapy at all. So the tumor is radiosensitive, staging is appropriate, and above all, the patient can withstand the treatment. Yeah, because all this, in as much as yes, you're targeting the tumor itself, a bit of the patient's normal cells also get involved. So you need to be at a point where the body's mechanisms can repair themselves well, or the body can withstand treatment. Yeah. So that is where you hear something that we call the ECOG 1, ECOG 2, 3, 4. Yeah. We basically assess if the patient can withstand this treatment. Mm-hmm. All right. And then after that, if they're in if they're in good shape, okay, they can withstand the treatment well. Now that's when you meet at dosing. Everything has to be precise. The commonest tumors we radiate are tumors of the esophagus, tumors of the cervix. You're getting where I'm going with this. Yeah. And then also radiotherapy has other uses apart from that. Assuming there's bleeding, let's say there's a mass bleeding, mm-hmm. Yeah, radiotherapy can be hemostatic. It can stop the bleeding. So there's a wide array of users. It really varies from patient to patient, mm-hmm. depending on the oncology assessment.
All right. So, Dr. Ari, are there instances where it may not be recommended for some patients, the radiotherapy, and some maybe things like chemotherapy? Are there instances where, based on certain things, certain patients cannot undergo those kind of treatments?
Yes. Yeah. Mm-hmm. In our world, you measure twice, you cut once. Uh-huh. Yeah, so if the patient is not of good performance status, let's say patient is not feeding, patient is weak, yeah, patient has low blood levels, that when you do what you call best supportive care initially. That is, you whip the patient up to shape, transfuse blood if needed and things like that, before the patient can withstand treatment. Remember, the principle is always you're treating the patient with the tumor. You're not treating the tumor in the patient. You'll be treating Bridget with the tumor. Mm-hmm. Yeah? Mm-hmm. Bridget will have have a tumor, not just the tumor and Bridget. So in whatever you do, you want at the end of the day to be able to, it's kind of like a tightrope walk where you're balancing control of the disease and also the well-being of the patient. Yeah, so it's a really watchful eye. It takes a trained eye to avoid the common pitfalls, the common mistakes that are made, that at the end of the day lead people to rejecting treatment. You know, saying, chemo is bad, radiotherapy is bad, you get treated, you die. No, in the right hands, yeah, that's like a loaded gun, yeah? In the right hands, in the trained hands, you have the ultimate weapon. But if care is not taken and shortcuts are taken, that's when things like that happen. Yeah.
What happens as part of the preparation for this treatment? I know you talked about staging and all the things that you do as doctors to just analyze this patient and to get their medical history and to understand what treatment will best work for them. But aside from what you're doing with regards to the medical history, Daktari, how do you prepare this patient for this moment when the treatment will begin so that they are psychologically and even physically endowed to be able to, withstand the whole process and for you to attain, positive outcomes?
Right, very good one. Now, standard of care, basic standard of care worldwide. I cannot legally do anything to you, any medical intervention, without you or your legally stipulated next of kin, assuming you're incapacitated, giving us informed consent. What do I mean by informed consent? It's a scenario whereby you've sat down with your doctor. Your doctor has broken down the entire process of treatment, has broken down to bits that you understand what they're going to do with you. So any patient has to give informed consent. All right, yeah, so there's the consent seeking. Now, during the informed consent bit, you sit down, you actually educate them on what is expected to happen to them. You give them the risks associated vis-a-vis the benefits, and then they make the decision and give you signed informed consent based on what you've led them. See, in our world, mine as your physician is to actually advise you, and then it's you as the patient or the legal next of kin to actually consent to that. So it's always informed consent, and it's never a one-day affair. We do have sit-downs where time allows. Yeah, ideally every step of the way. At any one point, a patient can tell you, pause, I don't understand, let's circle back to this. Yeah, ideally where circumstances allow. But every step of the way, the patient is informed. Yeah, the patient owns the process, the patient walks with you. Because at the end of the day, the patient's normal is not everybody's normal. Okay, maybe somebody operates at a HB of 10 standard and they tell you something has changed. I'm feeling dizzy, I'm feeling a bit more tired than usual. So you need that. For cancer treatment, you need patient ownership, you need patient involvement through and through. So there's a lot of education and sitting down that goes into this. It's never, oh, I have malaria, here's your Coartem, maybe meet you in another life or next time. No, for us, it's a journey you start with your patient.
All right, Daktari, there, Bridget Nyabuto, just telling us a bit about the processes that happen just moments before, they take the patient through the treatment process. We are focusing on radiation this particular morning. And Daktari, just to come back to you, sorry for that slight hitch we faced there, just to pick up from where you left, you were explaining to us how, this whole process of preparing the patient for the entire treatment plan, takes place. Just maybe to pick up on the point that you left at.
Okay. Sorry about that. Sorry you got interrupted. The internet is quite shaky on this side. Now, so there's, of course, informed consent. There's a lot that goes in bowel prep. There's a patient coming in. You take your CT scans, yeah? You find out where the tumor is lying, and then you go for what you call planning. This is whereby the radiation oncologist sits down and literally draws volumes. So CT cuts your body digitally, like slices. So we go through each slice, okay, identify the area where tumor is involved, map it out, map out the organs at risk, the ones that should not get in the path of the radiation in any way. After we are done with that, it goes through, like one of our seniors will still evaluate. It's never a one-person decision. After the mapping is done, and then after the volumes are drawn, and then after that, the patient comes in for what we call simulation. This is where we put you in a machine without actually releasing the rays, yeah? So to assess safety, to assess anything that has been touched, if there's a problem at simulation, we go back to the drawing board. So it's really a labor-intensive task, yeah? But everybody takes maximum precaution to ensure you're getting the right dosage of treatment. Yes, we do meter dosing for radiotherapy. Something interesting you can go look at. Yeah, so we determine the number of grays you're getting, the number of fractions it's going to come in, and above all, we map the sites, ensure we are very, very intentional about the treatment and about how we're going to hit the site. Yeah, and then you go for your simulation. We will draw new. So there's a lot that goes in. Above all, we ensure your blood levels are adequate, you're well hydrated, and you can withstand treatment. Now, sorry, I digress a bit, but please feed your patients. Hello, people, feed your patients. Okay. Yeah, this myth going round of, oh, once you have cancer, meat is bad. Once you have cancer, sugar is bad. Once you have cancer, yada, yada is bad. No, feed your patients unless it's well known that they have allergies or they're allergic to whatever food products you're giving them. Yeah, or unless there are prior existing dietary restrictions. Okay, let's say for somebody who has diabetes, for example, the diabetes doesn't simply go away because they have a cancer diagnosis. For somebody who's and is meant to restrict their sodium, for example, sodium intake, it doesn't go away simply because we got a positive diagnosis. So you're catching my drift. You're following. Feed your patients. They need the food. Okay, we cannot treat patients who are not well fed.
Especially in that time when they really need their nutritional their nutritions during that time that they are battling cancer. It's important that you said they need to eat, because that is the time a majority of them are choosy about the kind of foods they eat. So I believe food is important in this journey and in this war against cancer. Now that you have taken us through, and it's quite interesting how you have described the preparation. I didn't know that it was that intense, you know, you just trying to get a patient ready for the treatment and for the radiotherapy process. But now that you've taken us through the depth of how it's done, you've done all that and you've assessed this patient is ready for radiotherapy. You've given them the green light that now it's all systems go. We can now conduct this, treatment. So what happens? How does it happen? And just take us through how the radiotherapy session works, and probably how many treatments per week does a patient need? How long does it take? Just take us through, paint a picture for us on how that looks like.
Okay, let's see. Again, you'll bear with me if I go into too much detail.
I know you're passionate about this area, so feel free.
So after we've done all that, your planning, your simulation, it's as simple as this. Yeah, you simply present yourself as a patient. You go through your usual, a quick medical exam, maybe a quick one-on-one, asking if there's anything new that we ought to be aware of that might change how we will do things. And then you simply get in the machine. It's for those who've been in a CT scan, it's something similar. So you just get on the bed. Yeah, you just get on the bed. The planning has been done. The lines have been demarcated on your body. There's some ink we use to sort of, and then you're put on the bed. You're laying according to how you were lying during simulation. Okay. And then, the machine simply rotates around you. In about 10 minutes, you're done, you're out. So the toughest part is initially getting your CT scans, planning your simulation. But it's if you're going, assuming, let's say we were radiating your breast, it's maybe 25 gray in, okay, or maybe it's 50 gray in 25 fractions. So you're simply coming for 10 minutes every day. Like it's you walk in, you walk out. Yes, the patients who are on radiotherapy.
Okay.
You know the picture presented about the cancer patient. Oh, they're there. They need round-the-clock care. They cannot do it. No.
So 10 minutes walk in, walk out. All right.
Yes, walk in, walk out.
All right. But then, is it like a one-session affair, or do you need to do it frequently, and how regular?
No.
Yeah.
It's never. So there's like the dose you're meant to give. Okay. So it's broken down. So for those who've been through this, you'll see maybe something written like 50 GY, so that's 50 gray.
Yeah.
And hashtag, let me use the word hashtag, hash sign, maybe 25. So you give it in fractions. There's something we call fraction. Yeah, so it's stretched out over a period of time because your body can withstand only a bit of radiation at a time. Remember, it's really good, but too much of it leads to a cascade of events you don't want to start handling for your patient.
All right.
So metered dosing, carefully monitored. Yeah.
All right.
Stretches over a period.
Dr. Concerns have been raised about how it affects the body. What are the side effects, both short-term and long-term? And people who are concerned that, does it affect the ability of somebody having a child or not? Just address those gray areas for us.
Oh dear. Okay. Where to begin? About your ability to have a child, as women, there's a whole subspecialization of gynecology that has come up just to handle that. Yeah. So fertility post-oncology treatment is a whole new topic, but there have been some success cases. Yeah. Though generally locally we're not yet there. Like it's very niche. It's for those who have the means, those who have the access. Yeah. But there's a whole other discipline to that. So I'll put it in the back burner for a bit, and then we will come back to it. Yeah.
Okay.
Sorry, what was the other thing? My train of thought has been run off the track.
The short term and the long term impacts of radiotherapy.
Thank you. So the short term, some people, in some cases, very few, do get some skin reaction on the irradiated area, but we do have beforehand given instructions and steps to mitigate that. So it's an exfoliative dermatitis of sorts, yeah, where your skin can sometimes can sometimes dry and start falling off, yeah, scale dry and start falling off. But that is factored in. It's unfortunate, but it does happen to a few people. These things you cannot exactly predict how each and every individual will respond. But that's why patients are told, do not wash the area being irradiated, do not use soap on the area. So there are precautions we take beforehand to minimize that. And it's normally a smooth process if instructions are followed well. Yeah, but that doesn't mean one or two people don't get unlucky. But still, there are ways to mitigate that. That's why it's strict, close, almost petty follow-up to a certain extent by your radiation oncologist. Yeah.
All right.
Yeah,
I just wanted to take you into the cost implications, because usually the reason why I interacted with some information that some cancer patients, the deaths can be attributed to the lack of the financial muscle to go through the treatment and even explore the options that are currently there in the market that can help them successfully battle cancer. So the issue of cost of treating cancer in our country still remains a concern. I don't know what your thoughts about this area would be, Dr. Ari.
Oh, Winnie, I'd write a whole, 5 volumes of pamphlets about this, It is the reality, the sad reality is your average Kenyan out there cannot afford to get healthcare. Okay. I mean, it's, let's say, 2,000 per session, okay, per day, planning aside, volumes aside, simulation aside, the whole thing of getting into a machine itself. That's like, on average, about 2,000 per day. I don't want to speak for anybody. I mean, there are people who are running businesses. So Apologies if I've gone into your territory, but I'm just giving a general blanket example. Yeah. At the same time, you have to come live in Nairobi because it's a 10-minute affair. We rarely admit you in the ward unless it's dire. It's dire, and there's also other supportive treatment going on at the same time. So this is somebody, let's pick somebody who's come all the way from Bungoma for treatment of cancer of the cervix. Okay. So you have to live in Nairobi. You have to afford the means of transport to Kenyatta every day. Okay. After that, you have to afford the right food. Even if it's, the way we say NHI, okay, whatever is going on right now, it's meant to help. It's meant to be tax funded. Yeah, so there's the cost of moving here, there's the cost of where to stay, there's the cost of how to feed yourself, and almost always there's a need for top up. And this is for the lucky ones who've gotten tax funded support through the national schemes. Yeah. It's an expensive affair, and that's the point at which we lose most patients. So you find, like, for example, case in point, cervix, treatment has been done, your total abdominal hysterectomies have been done, like the uterus has been removed and everything. So you need this adjuvant. Many moment you tell somebody itabidi uje Nairobi, or you have to move to Nairobi now, that is it, you lose them. Like, the reality is harsh, and then also, there were very few machines. They still are very few machines, even regionally. I know there's a machine in Eldoret, but, well, there's also a machine in Nakuru. Everything else is centered around Nairobi. You have to come to Nairobi. So that it's not something your average Joe will afford. Yeah. So people die still waiting, or things that would have been easily sorted complicate with time. So yes, there's a huge gap. Cancer treatment is an expensive affair. So Dr. It is an expensive.
What would be your thoughts on how best this can be captured, even in terms of policy, the issue of cost and the issue of delocalizing, if I may use that term, these services to the very remotest part of the country, because the biggest concern has also been how these services are centered around Nairobi, and you have also alluded to that when you're giving your thoughts on the cost issue. So how do we move forward from this very sad state of denying access to treatment for cancer patients who really need it?
Okay. Number one, healthcare and access to healthcare is a human basic right. Okay. Let's not go committing genocide. Let's not go wiping out entire populations because we cannot get our act together. Okay. So number one, it should be a fully tax-funded affair. Okay. In terms of resources coming in. Remember the Abuja Declaration that we signed? 15% of our revenues would be redirected and dedicated solely to healthcare. That has never been followed through. Okay. Then number two, there was also the devolution of health bit. Services, let's not lie to each other. The services were never, the human resource was never meant to be devolved. Okay. Big right now do not have an oncologist. And even the few oncologists in training in the country right now are not assured of a job back home. And even if you go back home, you find yourself in a station where, yes, you have your skills, you don't have that radiotherapy machine there. Okay. You can barely afford the chemotherapy drugs that are needed, because even radio doesn't go solo. There's something called cisplatin, some radiosensitizer that we give, yeah? So you find yourself in a scenario whereby you cannot give that treatment. So let's do the right thing. At this point, it's a human rights issue. It's never politics. Okay. It's a human rights issue. It's genocide going on by people not funding healthcare the right way. So number one, equip your hospitals. Okay. Number two, employ enough trained human resources. Number three, just honor the Abuja Declaration. Healthcare is a right for everybody. It doesn't have, whether you have money in your pockets or not, you're still a human being first and foremost. Let's respect that. Then number four now, for healthcare, you generally look at it from two prongs. There's the curative and then there's the preventative. some other things that can be prevented ought to be prevented. Case in point, cancer of the cervix, where the mainstay of treatment, by the way, is that radiotherapy and that brachytherapy. We've been campaigning all over. Please vaccinate your little boys and girls. Okay, if they don't get HPV, there is a chance, a very high chance, that cancer of the cervix will not come. If they get human papillomavirus, well, let's talk in 10 to 15 years. She comes, that will sure be positive in most cases, that is. So there's the preventive prong versus the curative. The preventative,
all right.
Vaccinate your girls. The curative, please fund your counties. Please fund healthcare. It's a human rights affair. Yeah, you know the way you think national security, the way you think your KDF. That is the approach that should be taken to healthcare. It's not fair. It's not fair. Even as we are pushing for universal healthcare, we are going in with the standard in mind that, for example, somebody deep in Garissa, has the same access as somebody in Kiambu, for example. And we both know that's not true. Yeah, we both know there is serious lack of facilities and human resources. Please redirect the 15% you consented to back to healthcare.
All right.
And above all,
thank you. Thank you, Dr. Nyabuto. As we close this conversation, maybe in a few seconds, just give us your closing remarks and also look at the issue of the awareness that needs to be there. I don't know what you have read from your trends as experts. When people present for these tests, which stage of cancer is most having the most people? Because concern has been that many people come when it's very late. It's too late, for any intervention to be done at that particular point. So to talk to us about the need of awareness and also what is happening with regards to why Kenyans are taking too long to come and get their diagnosis.
Okay. First of all, there's that stark difference again. Lower resource settings, they will almost always present very late. Yeah, because Kenyans have very interesting health-seeking behavior. Most of them will do nothing unless they feel pain, they see blood. You get? Yeah.
All right.
Yeah.
All right.
So by the time of feeling pain and you're seeing blood, it's
too late.
A bit. So, yes. It's late. There's never too late.
Not too late, yeah.
Yeah, okay. So let's get in the habit of, if you do not understand anything about your body, have a high index of suspicion, go to an appropriate healthcare provider. Notice I'm being very guarded with my words. Go to an appropriate qualified health provider, who will back you up. That is for those who have the means, for those who have the access. I mean, you feel a lump in your breast, please stop. You know the way you get a noise in your car and you run to your mechanic? You don't go like, that could be the carburetor, or that could be the spark plug. You don't start playing guesswork with your car. Your body is like, whatever you do not understand, please come. Yeah, if it's caught early, that is for those who have means. If it's caught early, it's solvable. All right. Very solvable. You get to live symptom-free. You get a very decent symptom-free survival period. Now, for the have-nots, Winnie, it's a disaster. It's somebody will stay on with something. Somebody has like a breast wound, for example. The sore is open. It's oozing. It's necrotic. Somebody will tell you, I've just been putting flagyl and charcoal on it. Yeah, straight to your face. Like, let's get healthcare back to the people. Let it be accessible.
Thank you, Doctor.
Yeah, and then it also leads me to a whole other thing. I don't want to sound like I'm raining down on any other cadres in healthcare. We are all important, but let each cadre stick to its job description.
Thank you, Dr. Thank you. Thank you so much. That is Dr. Bridget Nyabuto, an oncologist. She was just coming to us virtually from Kisii County. Greet the people of Kisii for us as we wind up this particular program. And we were just talking about cancer treatment in the country and the status there about her clarion call. Let's go back to the commitment that we made as a country to prioritize health, put money where our priorities are, and of course also a challenge to each and every person who's watching this particular morning. Take your health as a matter of priority. The moment you feel something off, something that is not quite common or normal in your body, take action almost immediately. You may just save yourself something that may be worse in a few days or a few months. Thank you so much for watching the health segment this particular morning. Now that's how we wrap it up. My name is Safina Chengoma. It's been a pleasure doing this for you since morning till now. For now, allow us to end it there. Keep watching Citizen TV.